risk preventions and management of coronary dissections to avert myocardial infarction.
Good morning, ladies and gentlemen. I'm Dr. Zhang Jingyang from Kaohsiung Medical University Hospital from Taiwan. Today, my topic is about the rare but sometimes severe condition about the coronary dissection.
So in time because of the problem with the slide. So do you have any discussion question for the speaker? So may I ask Hugo, do you have any comments for the previous speaker?
This is a question for Juan. I mean, we know that you have been an advocate for early stage procedure in hospital setting. But I guess you do have to re-certify the patient. Some patients are at higher risk, they're pregnant, play a part, age play a part, so how do you re-certify them?
So I think the question is, what do you do? How do you stratify these patients? When you're going to do
landscape. Obviously, the creatinine issues, then it's judicious to wait a little bit at the creatinine reach baseline. So that applies to a minority of patients where you've got to use your judgment. Sometimes the issue is frailty and you really don't want to get into too much of complicated intervention. Sometimes the lesions are CTOs and you don't want to get into those. But for the majority of patients, I think it is, as a strategy, it's reasonable to say, okay, I'm going to fix the non-culprit before they leave the hospital in a couple of days. The only downside which I didn't mention is sometimes it becomes an issue with length of hospital stay, and payers can make an issue with, for example, in some healthcare environments, if you do a stage B in the same hospitalization, you don't get paid for it. But those are non-medical, political issues that you are navigating. Obviously, in that setting, you use your best efforts. But by and large, I would advocate doing it early, because these lesions are hot and these lesions are unstable, and we have seen patients discharged coming back 2 weeks later with another non-standing, this time in the non-cover, despite being amputated to us. So it's something to just keep in mind.
The slide is ready. Okay, so please go ahead and continue.
Sorry for the technical problem. Today my topic is prevention and management for iatrogenic coronary dissection, Avert myocardial infarction. Actually, this is a rare condition, but sometimes it's very severe. We have two complicated iatrogenic coronary dissection, usually start from osteal dissection and sometimes dissection to the basala centers, and sometimes the more severe type we refer to RT dissection. And the other one is the iatrogenic induced osteocoronary artery dissection. And the first one actually start from a case. Chen is a 58 years old woman, suffered from STD, so received primary PCI. And actually, the LAD is very severe cirrhosis at the TB2 flow. However, actually discovered the complete region is the right coronary artery. You can see the diffuse stenosis and near total lesion and the thrombosis at the distal RCA. Angioplasty and thrombus aspiration, thrombectomy. angioplasty and the aspiration thrombectomy, and finally we regain the tissue flow. However, before we stand in the force contract injection to catch the dissection in the ostia, and then the dissection rapidly extend to the basal sinus. This time is the dominant one first dissection. The iatrogenic aortic coronary dissection (ICD) is a rare condition. Usually the prevalence rate is 0.02% to the 0.15%, but the prevalence may be underreported. The complication may spread to the ascending aorta and the aortic valve, and sometimes leading to a life-threatening condition, and usually needs surgery or even death. Most common, usually involved in the right coronary artery, more than 85% is about the right coronary artery. Case of ICD, usually the catheter manipulation is the case because the large catheter and the long sharp curve. And sometimes the contraindication and usually the guide injury and the guide extension and the bubble or stent infection. Factors associated with ICD, the catheter type usually the GR4 and the M+1 is the guiding catheter. Guiding size usually more than the 6 French, and in the less common in the 5 French catheter. And procedure type and about 56% is during the PCI and 35% is in the diagnostic procedures. And CTO also associated with more high risk of ICD. The classification of aortic dissection, the dominant one is around the ostia. Dominant is the extension to the aorta, but then less than the 40 millimeter to the ascending aorta. The dominant class 3 is more than the 40 millimeter of aorta. And the mortality rate is low in the dominant class 1. However, in the dominant class 1, class 3, the mortality rate is up to 60 and 6.5%. And the surgery in the dominant one, only 9% patient needs surgery, but in the dominant class 3, over 14% of the patient needs surgery repair. Management of ICD, sometimes in the dominant one, the conservative, and in the stable patient, the conservative treatment is acceptable. Usually we need early flap standing from the proximal entry point to the distal flap. Some in the dominant 2 to 3, and we need a cover stent, or sometimes we need cavity to open the upper closed vessel. And sometimes we need a mixed strategy, like the standing the ostia and do the aortic repair, or sometimes need a valve repair. So in this case, we do the standing, but the dissection extension greater is low after finally, the dry-eluting stent cover the ostia. You can see there's still the contrast injection into the dissection lumen. So I think not only the dissection extension gradually to the ascending aorta, or this is become a dominant class 2-3 aortic dissection. So you can see when we injection actually, there's dry-eluting stent that cover the proximal ostia, but the dissection flap extension, so it's the extension and more than the range of the stent. So we do another cover stent, and after the cover stent, we try to do the barbell angioplasty to cover the proximal entry point. After the cover stent, the final angiography showed a good result and no more contrast injection into only a little contrast injection to the dissection flap. And the patient now is free from the chest pain and his vital sign is stable, so we stop the procedure. And 2 days later, we do the computed tomography. We can see the normal aortic dissection after 2 days. Follow up the coronary angiography 9 months later, and there is no more coronary dissection and no stenosis in this coronary artery. So in the stable the vital sign, use the vasopressor or IVP. In case of dominant one, we can do the conservative or the standing. And in the case of more severe type dominant 2 to 3, we have to use the cover stem or means cover surgery to do the repair. And the other one is the iatrogenic catheter-induced posterior coronary artery dissection. This study is a 70 years woman, and due to the intermittent chest tightness and strong positive for the tremor test, the admission for the coronary angiography. This is coronary angiography, the left coronary artery, non-significant stenosis. However, when we see the right coronary artery, we can see a severe stenosis at the segment 1 and near total lesion. The first operator used the jacking guiding catheter, cutting 3.5 French, but the pressure is dumping. So you change to another guiding catheter, SCR 3.5 with side hole. So with the side hole, you can see the blood pressure, so you feel very safe. So after the injection, the contrast, and you can see, and maybe his guiding is in the fourth movement. So the injection has a very severe dissection in the right coronary artery. However, he did not give up, so he used the wire trying to find out the true lumen. However, the wire is in the fourth lumen, so the dissection is more and more severe. And EKG shows ST elevation and RCA-CTO with the osteotype D dissection. Where is the true lumen? This is the ICO-CAD. The overall prevalence is very low, 0.09%. Usually induced by the guiding catheter, and over the situation, guiding catheter increase the risk. And some patients, about 6% of the patients die in the hospital. So why in this case, usually the case of the ICO-CAD, the aggressive catheter shape like AL, SCR, or EP will cause the dissection, and the non-cohesive alignment and deep intubation of the guiding catheter. And some of the cases is about the operator, the forced contra injection and the guide-wire trauma or osteoarthritis will cause the ICO-CAD. And how to management the ICO-CAD? Usually the 80% of the patients undergo the PCI for the management, and some of the patients the remaining patient should receive chemistry or conservative management. So the key point is to assess the true lumen. So first, we have to stop all the selective contra-injection because it will worsen the condition. Second, we can have to use a soft non-hydrophilic workhorse wire with the low deep load and carefully winding the wire. Usually, the resistance or forming a sphenoid or knuckle shape of the wire is in the first lumen. But we do not remove the wire. We have to disengage the guiding catheter and try another wire to advance into the side branch and get into the true lumen. Usually, because we cannot use the contra injection, so IRS guide winding is very important, and sometimes we could get a more bigger working lumen, so we have to use the people guiding catheter technique. So this is the image. In this condition, we have the guiding catheter in the fourth lumen and wire in the fourth lumen. So we carefully disengage the guiding catheter, then use the IVAS to see the condition of the RCA ostium, then use another wire under the real-time IVAS guide to run into the true lumen. So this is the image. We leave the IVAS in the fourth lumen and pull back the IVAS. This is the IVAS image. We can see the IVAS is in the fourth lumen, and below the IVAS, there is the true lumen lying in the cystograph. And when we pull back the guiding catheter, we can see that in the ostium, the true lumen is still there. So we winding the other wire winding under the IVAS guide winding the steel wire, and we try to talk the wire slowly and from the ostium ostium and turn into the aorta, turn into the RCA, and you can see we need the wires in the other lumen. So we use IVAS to check the lumen. In the IVAS image, the lumen is in the wire is in the true lumen. So we try to advance the wire to the more and more distal to make sure that the lumen is fine and to stabilize the wire. After within the 1 minute, the wire is in the PDA. So we check the IVAS image. You can see the second wire is in the true lumen of the RCA. We try to do the barrier angioplasty, but due to the dissection and the calcification of ostium, the barrier cannot cross, so we use the expressment for the extension. And then the barrier angioplasty. After the barrier angioplasty, we can see the flow to the distal RCA and the chest pain improve. ST return to the baseline. We check the IVAS again in the true lumen. You can see the very deep dissection lumen in the RCA, but our IVAS is in the true lumen from the dissection segment to the ostium.
Sorry, Dr.
The barrier angioplasty and standing, and after the standing, the final result is good. And only a little ability of program and patient is free of chest pain. So conclusion, the ICO, CAD, and ICD is a common condition, but life-threatening complication. So usually related to the cardiac catheter, and we need use the image to guide us to even the problem. The IVAS is very helpful. Usually we need osteo-standing to manage the problem, and sometimes the very severe condition, surgery is necessary for the patient. And thanks for your attention.
Two cases of coronary dissection. So may I ask Dr. Ong and Dr. Jun, any of you have comments for the cases?
So, thank you for all the speakers. I would like to ask the speaker first. So, regarding the intervention in ICS, how about if the patient has survived from the cardiac arrest? So, how immediately we should put the patient into the cath if it's the ECG shows no response?
So you mean that the person we can do spontaneous circulation, but there is no standard. The thing that we have to clarify is how about the mental status. If it is awake, then we can also find is there any hemodynamic compromise others that decide it's not in all patients with rose, then the pressure is okay, something like that. So we have to maintain the hemodynamic, and then we will, if there is any evidence to ischemic, and the enzyme also increase, there is a reason for us to send the patient to be, I think mental status was. But if it's in comatose, non-operable,
Thank you.
And I have a question for Dr. Rija, and thank you very nice speech about it is undoubtedly that we have to do the convolutions at on-site. But I have two questions to raise. The first is that since we know that we have vasculitis for some kind of pain, so probably for some lesions we have to send in for the surgery. The catch, what times, what's the time usually is the best for us to send in? Because in Taiwan, my colleagues are always reluctant to do that in the index hospital. They feel that it's too dangerous for the myocardial. The second, and the second is that for the previous session, I enjoyed Dr. Coney on the floor about the new idea about obstructive MI. So our definition basically on the ECG is the ST derivation or not. So probably you have age response ST presentations, but on the CAS lab we have the real. So what would you like to do? Thank you.
So I think that's a great question about, what do you do if the disease is surgical, so you fix the culprit and you're going to then surgically treat the other vessels. It's not very well studied, to be honest, how long do you wait. The biggest barrier is that there is DABT on board and the surgeon wants the DABT to come off before they operate. And so I think that sweet spot is something in the order of at least a month, ideally 3 months, and that just depends on how critical the opposite non-culprit side is. So if you've got 99% left main disease, then I think your best option is balloon the culprit, don't put a stent, and then send it to surgery. But if the left-sided disease, the non-culprit disease can wait, then I think between 1 month and 3 months is a reasonable time frame before you send it to surgery. So sort of a hybrid approach. Was there a second question directed to me? So regarding this OMI-NOMI concept, which is occlusive MI versus non-occlusive MI, occlusive MI being basically a vessel that's occluded but not necessarily presenting with ST vision. I would approach it just like a STEMI, use the same thought process that if they have non-culprit disease, I'm going to fix it and I'll typically go into the same hospital stay if I'm able to do so. So I don't need to get rid of it.
So thank you. So I think the chairman is there, and then everybody is ready for the opening ceremony. So I think we have to close this session. Thank you very much for all